Morning, everybody. So, I and to organize this for share our experience and osteoarthritis. It has been stated that osteoarthritis is a problem, and since 1743, John Hunter has stated that the ulcerated cartilage is a troublesome disease and that when destroyed, it never recovered. So when the cartilage is damaged, there is no treatment for that. There is nothing at present which can recreate the destroyed cartilage. So arthritis is a major problem in our population. The definition, the word arthritis is derived from Greek. Arthron means joint and itis means inflammation. It's simply the inflammation of the joints, and there are more than 100 forms of arthritis described. The American Rheumatologist Association has classified arthritis based on the etiology into 10 major subgroups. The first is the polyarthritis, which is different types like rheumatoid, juvenile rheumatoid arthritis, ankylosing spondylitis, which there is associated fusion of the spine, psoriatic arthritis, which has associated skin lesions, Rhetus disease, and arthritis associated with rheumatic fever, degenerative joint disease, which is called osteoarthritis, arthritis due to infection. Of these, osteoarthritis and rheumatoid arthritis are the major arthritic problems we face. Other conditions include traumatic biochemical disorders like gout, tumors, congenital disorders of the collagen, and miscellaneous conditions. The overall incidence is around 40 to 50% in the population. In Indian scenario, in urban population, it is slightly higher. It is around 56%. Based on the studies conducted at Delhi and Chandigarh. To see a population distribution, presently we are 1.2 billion population. We see the distribution of the population around more than 65 years is around 58 million now, and there are more people living longer, healthier lives. So the incidence of arthritis increasing with the increasing population. So in 2020, there will be a lot of people, elderly people with arthritis, whom need to treat. The osteoarthritis is also called degenerative arthritis. It's also called wear and tear of the joints. The prevalence is more in elderly population. It's the leading cause for pain and disability in this population. It affects various joints, mainly the weight-bearing joints. Most common is the knee joint, like hip and hip joints. It affects the spine and foot joints. In the hand, it affects both the proximal and distal interphalangeal joint. But compared to rheumatoid arthritis, the incidence of the proximal interphalangeal joint is commonly affected in rheumatoid, while the distal interphalangeal joint is affected in osteoarthritis. Knee arthritis is more common in Asian population compared to the Caucasians or the Western population, mainly maybe due to, we don't know the specific reason, but could be genetic or people's habit of sitting down or walking on uneven terrain, or customs like sitting cross-legged or obesity. You see, rheumatoid arthritis, it affects both the sides symmetrically, and it involves the small joints more often than the major joints. Major joints are affected later. Usually there is symmetrical distribution, both sides are affected, small joints more commonly affected, while the osteoarthritis affects the major weight-bearing joints. Rheumatoid arthritis leads to deformity of the foot and toes and deformity of the knee joints. It consists of a matrix with chondrocyte cells. The matrix has mainly water with molecules trying to hold the water molecules in place called proteoglycans. What happens with age, the amount of proteoglycans is reduced in the joints, so the water content comes down. This leads to breakdown of the collagen matrix, and finally the cartilage breaks down. This leads to pain. To see a normal joint here, there is a shining yellow is the articular cartilage. The early stages in the younger individual, it is intact. With age advances more than 40 years, there is some fibrillation of the cartilage. Gradually there is breakdown of the cartilage, and finally the entire cartilage goes off and the subchondral bone is exposed. When this raw bone gets opposed in each other, we get severe pain. So this area we can see there is no cartilage. So this femoral bone comes and rubs on the tibial bone, which causes lot of pain. This is a normal knee joint. You see the thigh bone and the tibia, femur and tibia. There is a normal joint space. In between there is a 4 mm of articular cartilage. So with load is equally shared between both the compartments of the knee joint. With age advances, the cartilage becomes weaker and there is loss of articular cartilage. There is new bone formation here, and deformity develops and instability develops, and gradually they go into severe bow legs. So this is how the arthritis progresses. This is a natural history of arthritis. So what are the risk factors for osteoarthritis? First is the age. So as I said, as age advances, the incidence of arthritis increases. Females are more prone for knee arthritis compared to males, while males are more prone for hip arthritis. Obesity has a clear association with the incidence of arthritis. You see obese elderly individuals, there is almost 100% incidence of arthritis by the time they get to 50 years or 60 years. While the non-obese individual, the incidence is only 50%. Other occupation-related repeated trauma, sports injuries, previous surgeries, and bone deformities like bow leg or congenital abnormalities of the cartilage all predisposed to arthritis. So what are the symptoms? Patient presents with pain. But how is the pain? First, the early disease, the pain is appreciated only after a period of activity. They can walk for a period of time, they develop pain, they need to rest, and then they walk again. But when the stages, there is pain even at rest. Even at night, they are not able to sleep, there is severe arthritis. Sometimes there is locking or giving way. There is stiffness. They say initially when they get down and they are not able to walk, after they walk few meters, they are able to carry on. So this stiffness is less than, usually lasts for 10 minutes or 15 minutes, usually less than 30 minutes. There is a differentiating feature between this and the rheumatoid arthritis. They have early morning stiffness. The morning they get up, they all feel very stiff. It lasts at least for half an hour. For other osteoarthritis, it just lasts for a few minutes, 10 to 15 minutes, then they are able to walk. What are the signs? There is bony enlargement. You see the joint, you feel the joint line. There is a new bone formation there that feels like a bony enlargement. There will be crepitus when the bones are rubbing, there will be crepitus. The effusion, there is effusion that is not warm, called cool effusions. Then sometimes you can see effusion in the back. You can see the knee is swollen here with tense effusion. The movements is decreased, the range of movements decrease. There is tenderness in the joint line. When you move the joint, it's painful. You see the X-ray, there is typical changes in osteoarthritis. There is a decrease in joint space, there is a normal joint space. Here the joint space is decreased. There is subchondral sclerosis. This bone, due to loading, abnormal loading on the inner aspect, the bone here becomes thickened. There is remodeling here, thickened. There are osteophytes. These new bone formation are called osteophytes. They try to support the weight bearing here. They increase the articular surface so that load is shared in this portion rather than being point loading. And there will be some cyst in the subchondral region. You can see the patellofemoral joint, there is no space in between, there are new bone formation. When we move, there is crepitus in this area. So coming to the differential diagnosis, first is the bursitis or the tendinitis. These situations have caused localized problem. For example, bursitis, there can be a bursitis on the medial aspect of the knee, or a tendinitis maybe in the patellar tendon, the lower pole of patella, you can have localized tenderness. If you feel for the specific area of tenderness, you are able to appreciate. But in arthritis, there is diffuse joint line tenderness all around the joint. Secondly, inflammatory arthritis. Usually in inflammatory arthritis, there are other joints also involved. You look for the small joints of the hand, wrist joints, elbow joint, or shoulder. They generally have other joint involvement. Third thing is the infectious arthritis and the microcrystalline arthritis. Microcrystalline arthritis includes gout and pseudo gout. So in this situation, there is marked warmth and erythema. There will be redness and the joint will be generally warm. Other causes like rheumatoid arthritis, they have multiple other associated problems. Like in rheumatoid, we have other joint involvement, subcutaneous nodules, lung involvement. We look for the other features. The differentiating features in rheumatoid arthritis, there is concentric reduction of joint space. You see the joint space is evenly reduced, but in arthritis, osteoarthritis, there is mostly medial compartment, sometimes lateral compartment. But in rheumatoid, it's global concentric reduction in joint space. Secondly, in crystal-induced arthritis, you can see the minuscule calcification, deposition of the gout crystals into the cartilage and the intervertebral disc in the spine. So you can see them in the X-ray. In neuropathic arthritis is due to the loss of nerve supply. They can have a spine problem or injury to the nerve or a childhood poliomyelitis. The joint is totally disorganized. The joint has feedback to the nerve endings. You know the knee is bent or straight from the feedback from the proprioceptive nerve from the joint. If that is lost, the total joint becomes disorganized. So these are the differentiating features. So compared to osteoarthritis and rheumatoid arthritis, you see a lot of newborn form osteoarthritis. Compared to rheumatoid arthritis, there is not much of newborn formation. You can see a lot of sclerosis of the bone. Bone is sclerosed. Here the bone is osteopenic. The bone density is reduced in rheumatoid arthritis due to inflammation. You see the differentiating features between osteoarthritis and rheumatoid arthritis. Here there is a reduction in joint space, but the difference is here it is localized to one compartment, but in rheumatoid it is two compartments. Then there is a cyst here. You can see the subchondral cysts. Then osteophytes are newborn formation. In rheumatoid there is perichondral osteoporosis and some resorption here. This case you can see the resorption. So that's how you differentiate the osteoarthritis from rheumatoid arthritis. Diagnosis, X-ray is the gold standard. You see the patient has a effusion, a joint line tenderness, pain while walking. So you ask for an X-ray. X-ray is mostly is a diagnostic in osteoarthritis. If you have a doubt, if you think of other, want to rule out other problems, when you do a blood test. So for example, to rule out rheumatoid arthritis, you ask for a rheumatoid factor in the blood. So then again, if you have a doubt whether it is infection or crystal-induced arthritis, because the treatment is totally different from osteoarthritis. So you need to aspirate the fluid and see what is it and send it for testing. So in this patient came with a huge fusion in the knee joint. We had a doubt whether it's infection. We aspirated it, drew frank pulse. So this is infective arthritis. He suddenly deteriorated. We need to intubate him because the infection in diabetic patient with elderly patient is very life-threatening. We also have features of gout. There is deposition of the urate crystals. So we need to differentiate between whether this is a simple gouty arthritis or infective arthritis or secondary osteoarthritis. So in these situations, aspiration is very helpful. As such, there is no cure for arthritis with medications. So the main goal of the treatment is to reduce pain and keep the joint moving. So we classify the stages of arthritis into 3 stages: mild, moderate and severe. Mild arthritis, patient has pain after a period of walking. After that, sometimes they take rest and keep on walking. There is mild effusion. There is slight limp on walking. It's a first stage called mild arthritis. The second stage might need some support, or the limp is severe. The pain doesn't go off. They might develop rest pain in the night. So this is moderate arthritis. As I said, goal is to relieve pain and enhance function. Treatment for first and second stage of arthritis is mainly non-pharmacological. So the initial treatment will be rest. Use of physical therapist forms a major role in these patients, and we advise them to avoid stressing the joint, like avoid sitting down on the floor, avoid frequent climbing of the stairs. Some local applications, give braces and shoes support. One more thing is weight reduction, and teach them about the management of chronic pain. This pain is going to be there for many years to come. So the role of a physical therapist is very important in the first and second stage of arthritis. The physical therapy improves the muscle strength and the proprioception and reduces the progression of arthritis. When we walk, 50% of the weight is going through the bones and the 50% is taken by the muscle. So the muscle has to be in good tone to reduce the load on the joint. So we emphasize on physical therapy. The physical therapy should be individual based on the age, comorbidity and overall mobility of the patient. And patient education is very important to promote a positive lifestyle. We ask them to keep active. Generally they ask whether I don't walk, I don't have pain, so can I take rest? If you completely take rest, all the muscles have become weaker, then it only aggravates the problem. We tell them to be active and have a positive lifestyle. And group exercises and home exercise are also helpful. And you need to have strategies to keep them in the physical therapy, because most of them don't follow the therapy. And they need the support, social support also. They involve the family and friends and reinforce the use of medication appropriately. So 30% of the patients don't take the drugs, prescribed drugs, and 27% of them are non-compliant with exercises. And 65% are non-compliant with assisted devices. You give them, ask them to have a cane or a brace, they don't use it. Then other treatment modalities include thermal therapy, heat therapy, cold and electrical therapy. Osteoarthritic patients prefer heat therapy because it reduces stiffness, reduces the pain, and reduces the spasm, help prevent the contracture. So this rack patient or use a hot water bag to apply heat therapy. It improves the elasticity of the joints and gives some pain relief. There is acute flare-up of the arthritis. Then we give cryotherapy. It's a cold pack which can be applied over the joint. It improves the range of movement, function, and the knee strength. Cold causes vasoconstriction and decreases the edema and has an anti-inflammatory effect. The other physical therapy include TENS. Exercises improve the muscle strength. They reduce the joint pain, joint swelling, and stiffness. It replenishes lubrication, decreases bone loss, maintains posture and prevents deformity, provides stability and prevents fall, especially in these elderly patients. So exercise therapy is very important for this patient. The exercises can be graded this way. Initially you teach them range of movements, secondly muscle strengthening, third aerobic, and fourthly recreation. Range of movement exercising include flexion, extension and stretching exercises. Muscle strength, we put some half a kg or 1 kg weight and then ask them to do muscle strengthening exercises. Mobility training, ask them to use some supports while climbing, while using a commode. We can use some arm support to sit and get up. It will helpful in day-to-day life. In fitness, they can have brisk walk, swimming, or aerobic exercises, or even dancing. And hydrotherapy has a lot of role in Western countries. We don't do it here, but hydrotherapy also has a good role. Weight reduction is one of the important aspects of the treatment. Weight reduction combined with exercises has shown a lot of improvement in these patients compared to just medications or just physical therapy. So weight reduction has to be combined with this. To see a normal joint, there is a load across a normal joint is almost 4 times the body weight. It's not our body weight is going through the knee joint, it's actually the 4 times the body weight goes through the knee joint. There is 2.5% going here and 1.3% going here, and it is contracted by 3 times the load from the muscles. So if you have a normal joint distribution like this, so if you have a deformity like this, the entire load is on the medial compartment. So a lot of load is going on the medial side. That causes a lot of biomechanical problems and pain. So they introduced the orthotics to reduce the load on the medial side. They thought they'll put some metal hinges on both sides and reduce the load on the joint. So they bought the unloaded brace. But actually what does work? It doesn't work like unloading. It reduces the muscle co-contraction. Normally when we walk, the muscles in the front of the knee has to contract and the muscles in the back has to relax. So, but in arthritis, both the compartments contract together, pressing both the joints and bones together. That causes a lot of pain. So this brace only reduces the muscle co-contraction. Doesn't change the biomechanics. So other lifestyle and home remedies also advised. And the drugs include acetaminophen. Paracetamol is the mainstay in early stages, and tramadol. These new counterproductive drugs have come, glucosamine and chondroitin. The effect is not proved but still being given. Other thing is intraarticular injection, injection into the joints. You can give either a steroid injection or hyaluronic acid. Hyaluronic acid is what is found in the joint synovial fluid as a lubricant, and it is synthetically manufactured. It can be injected inside, but all the effects are only short term. When the cartilage is damaged, it's not replaced. So if you use hyaluronic acid, this is counterprotective effect. So it doesn't cause further wear and tear for a short while. So supports like cane are also helpful, reduce the load on the joints. We come to the next stage, severe arthritis. This patient has severe arthritis, bowing. You can see a co-contraction. The entire leg moves as a whole. All the muscles are contracting together, and she is finding it difficult to take even steps. Turning is very difficult. Getting into the bed, getting out of the bed, going to the toilet, everything is difficult. This is a severe stage. So the joint is bent, deformed and totally unstable. Next stage, what is totally becomes loose and patient not able to weight bear on the leg. So this patient is not even able to go to the toilet. It's totally bedridden. This is the last stage. So treatment options in severe arthritis include strong painkillers, cortisone injection, viscose supplementation. But surgery is generally advised in severe arthritis, which is not relieved by all the other modalities I mentioned before. So surgery in osteoarthritis can be in 4 broad categories. First is joint replacement, second is arthroscopic debridement, third is realigning the bones, called osteotomy, fourth is the fusion of the bones. At present stage, fusing the bone is not considered unless there is infection. So arthroscopy sometimes we do. It gives temporary relief to the patient. We do clean up the joints, remove all the loose fragments, debride the cartilage. At present, a lot of attention is being given to the stem cell therapy. So what they do is they do multiple drilling and inject some stem cells here, or take some cartilage grafts from the non-articular side and put it in place. Then they say it is growing, but it's not fully into place, still in the experimental stage. Osteotomy is to realign the weight distribution. So the load is coming on the middle side. They do a osteotomy here and realign the bone so that the weight distribution is even. So this is an example of an osteotomy. Coming to the last thing, joint replacement. Joint replacement solves all the problem of arthritis in a patient with severe arthritis. It gets back to the correct alignment, provides stability, the instability is prevented, and relieves the pain and restores mobility. So what we do in joint replacement, we remove the damaged portion of the lower end of femur and replace the metal component, remove the upper end of tibia, all the damaged portion is removed and replaced by a metal component. In between, instead of the cartilage, we put a polyethylene insert, and sometimes if the patella is damaged, we replace with a plastic component as well. So we just resurface the joint, we remove only the damaged portion and put a component inside. So patients are able to bend the knee the next day, they are able to walk the first or second day because of the good pain relief. So the patient is 7 days after a joint replacement, both sides done. He is able to get down, walk, he is already able to bend more than 100 degrees. He is very comfortable. So it solves all the problems of arthritis. So this patient has a limb pain in the right knee, valgus deformity, it's an outward bowing. So after surgery is walking, you can compare the gait before surgery and after surgery is walking almost normally. So one more example, bow legs. You see most commonly in rheumatoid arthritis, that can be corrected. So the same patient you saw a few minutes back, is walking almost sheer speed of gait. So she has a happiness in her face. So joint replacements is a good relief of the arthritic problem. This patient was totally dependent on the relatives to go even to the toilet. He is able to walk independently. Just one more example. The fear of surgery puts them off from coming to the doctors. So they don't want to have the surgery unless they are totally bedridden. So this patient is, this patient is a father of an ENT surgeon, but he was never able to convince his father to come for the surgery. So finally he came on, he became totally bedridden, and now he is able to walk. So what does joint replacement give? Not only gives relief from pain and mobility, it has also physiological benefits. The patients, once they start ambulating, it improves the heart and lung fitness, diabetic control, prevents osteoporosis, prevents obesity. It also has psychological benefit. If you are independent, there is less anxiety, there is a sense of well-being and relaxation. And for whom there is a surgery, the patient has day-to-day routine, the restriction of movements, and they avoid going out due to pain or walking, avoid exercises, and their world becomes very smaller. So what is the cost? The knee replacement cost 1.4 lakhs, and the general ward 1.2 lakhs. Duration of stay is 7 to 12 days. Many patients say they have spent maybe more than a lakh over a year for medication, physical therapy. So, but compared to that, what they spend over many years, joint replacement is more cost effective. Under the Tamil Nadu Chief Minister scheme, it is done free of cost for the poor patients. Both CME, the joint replacement are done free of cost. How long it lasts? Is there a joint for life? There is a next goal when you try to do a joint replacement. There is at present 15 years survival is almost 98%. 98% of the works still work at 15 years. So now they introduce a computer-assisted joint replacement, high-performance implants, new bearing options to improve the joint replacement life. So maybe the present joints will work for 20 to 30 years, we don't know. So the navigation-assisted surgery, we are able to do the surgery with help of computer navigation. You are able to restore the limb alignment, and you are able to see on the screen whether the leg is straight or bowed, what size components you are able to put, whether ligaments are balanced or not. So it's a very good advancement in science. So we expect the life of the populace to improve. So this is just a 45-year-old lady with arthritis with severe bowing. We are done with computer assistance. You can see the post-op limb alignment looks perfect. This lady severe arthritis, both legs bowed, hardly able to walk. So in these stages, nothing can help them except surgery. So after surgery, the limbs are straight. The newer designs have come which allow patients to bend more than 120 degrees, and the polyethylene quality has improved. So they are able to sit cross-legged, even pray at a temple or a Muslim patient, they want to bow down and pray, they are able to do it. So they introduced the newer designs. We will call the rotating platform, high flexion design. It not only bends, it also rotates. So these are the newer advancement at present. Now they introduce oxenium. This is a type of ceramic. Previously have cobalt chromium alloy. We have oxenium, so which is said to last longer. Maybe the joints will work for 30 years. Once you get a replacement at 60 years, probably it is going to last you a lifetime. There is a problem with metal allergy in 3 to 8% of the population. So this oxenium has been known to solve the problem now. So coming to the other joint, there is a hip joint. So if you see the hip joint, there is a normal hip with a acetabulum and femoral head. There is a cartilage in between. So what happens similarly in arthritis, there is breakdown of the cartilage, there is wear and tear, there is pain. The most common problem of arthritis hip in India in young population is avascular necrosis. Due to various reasons, the blood supply to the femoral head is cut off. The femoral head gradually becomes weaker and collapses. This is a major problem of arthritis in young population in India. It's very common in India. In abroad, it is usually arthritis in hip joint is very common in elderly population. But in India, it is arthritis. Second to arthritis, they have some childhood problem in young age. So they develop arthritis probably in 40 years time. Then they require some surgery. As I told you before, osteoarthritis and rheumatoid arthritis are other common problems. So what we do here is replace the femoral head with a metal component and replace the acetabular side with a plastic or metal component. So John Lee has introduced the hip replacement surgery. In his times, he used polyethylene liner and stainless steel stem. But now we have evolved so much. We are having different components. It's a cemented total hip replacement. Then we have uncemented total hip replacement for a younger patient, which works longer, more than 15 years. So this is an example of the young individual with a fracture is replaced. So initially we said when you do a hip replacement, you can't bend more than 90 degrees. You can't cross over the leg. You can't turn to the sides. Don't bend more than 90 degrees. This put off a lot of patients away from surgery. So we ask them to use a table chair lifestyle, use a chair, use a western toilet. So now we have the high performance bearings. We have the special plastic ceramic liners with large heads, which will allow even sitting on the ground, cross-leg sitting. The oxenium heads have come, which they are very less. So this is a young patient with arthritis. It's only 16 years. The right hip is totally arthritic. The hip joint pelvis is totally tilted. Right hip is down, left is up. So even the young age arthritis can affect individuals, and they can be treated with joint replacement. This is a school-going boy. This is almost normal after surgeries. Get back to normal. So the newer options are available for our patients. One more young patient, joint replacement, avascular necrosis, and sometimes they come very late. Then we need to use some special implants like this. They have not walked for many years. The bone has become damaged. We need to metal augments. So the purpose of modern medicine is to make people live longer and also younger. And I conclude with this. Thank you, and thank you for the opportunity.
Detailed presentation on diagnosis and management of osteoarthritis according to the conventional medical system. We thought it's essential because especially in moderate to severe conditions where we have certain shortcomings, but we in fact we manage better with the care you have.
See, and combined with this, what treatment you are giving will give very good relief for the patients. So the end stage, you might need to operate, but a lot of people with moderate and severe arthritis might be coming across day to day. A lot of our patients are treated by physiotherapists. They come and see us once and they are followed up with physiotherapists. Similarly, what I saw a lot of patients here with severe arthritis walking after your treatment.
Yeah, this is, coming to the conservative management, I think we do follow most of the principles that you have mentioned, but something which is strikingly different is the oils that we use. So we don't know, I'm just curious to know what is, as an allopathic doctor, your perception on the application of oils, because that is what makes Ayurvedic treatment very different from conservative management in modern medicine. Do you have any opinion or your outlook on?
As such, we don't prescribe oils, and we give only creams. Oils, mostly patient already are having this oil, they get it, Ayurvedic oils probably, most probably, they're already applying it. So we say you continue with whatever you are happy with it, you can apply any external application. It works by a gate control therapy, gate control theory. There are pain fibers starting from the knee, which is going through the spinal cord. And there are fibers from the skin, from touch sensation, both go to the same gate. So when you stimulate the touch sensation in the skin, the gate is closed. There is no sensation from the joint which is causing pain is going back to the same gate. So you stimulate the skin and surrounding tissue. So you block the gate for the pain sensation to go up. So you apply oil on the front, there is some counter irritation, and patient don't feel the pain from the joint. So it's called a gate control theory. So I don't know what principle this your thing works, but what our creams and work this way. They block the sensation from the appreciation of the sensation from the joint, arthritic pain. Counter irritants. Yes, they also combine with non-steroidal anti-inflammatory drugs, which will absorb through the skin as a pain, acts as a painkiller. Mainly, it is a counter irritant action. So they don't feel the pain inside. Temporary relief.
So oils are acting not as a painkiller alone, it's supposed to relieve the stiffness, and also some doctors even claim that it re-lubricate the joint. But like glucosamine and chondroitin thing, the glucosamine is a supplement.
That could be counterproductive. Such there is no proven benefit. So we don't have a proper long-term study which has definitely shown benefits. So we still give patients, we can try both the
as a supplement.
The supplement, the vitamin. Don't know actually what happens.
I'll ask the question in the modern perception that we would like to know is, you ran over a slide quickly over the diet aspect and you didn't elaborate on that. So I would like to know what is the modern concept, what kind of diet you would say for a knee pain to relieve, A. And question 2, when you prescribe non-inflammatory drugs, is it more of a pain relieving or is it going to prevent the further degeneration? So what you do with further to prevent and so that the patient doesn't undergo the chronic stage of the disease, the modern perception of it.
The diet, we don't feel there is any correlation between the diet taken and the symptoms. A lot of patients say they have particular vegetable increases, As such, in our medicine, there is no correlation. Our diet prescription will be to reduce the weight, avoid all the food material which is going to increase the weight. We prescribe a balanced diet and not to put on weight. Our main concern is to reduce weight. There is nothing to do with arthritis. Our aim will be to reduce weight and control the weight and get an ideal body weight. So our prescription of diet is only that. We don't have any correlation with the symptoms. Secondly, there is no drug which can prevent progression of arthritis. Only thing shown is weight reduction and physical therapy. These two can decrease the progress of arthritis. Patient doing regular physiotherapy and maintaining a good body weight, ideal body weight, it is shown to decrease the progression of arthritis. The drugs given is only the NSAIDs will reduce pain. Secondly, reduce the amount of effusion in the joint. If you have a very swollen joint, the range of movements is reduced. There is a lot of pain. The drugs to reduce the amount of effusion in the joint will reduce pain. It doesn't stop the progression of arthritis. At present, there is no drug which is proven to reduce the progression of arthritis.
Thank you, doctor.
So I would like to know what is if both the knee joints are affected and both knee joints have to be replaced, is it advisable to be done simultaneously, or what is the gap which has to be given? Or if one has been done and due to certain circumstances the other could not be done, what will be the consequences? That's one thing. And then next one is is there any direct relationship between osteoporosis and occurrence of osteoarthritis in such patients with osteoporosis?
Timing of joint replacement, generally if there is deformity on the both sides, we advise both sides to be replaced, because once you replace one side, the limb alignment is restored. The other side is still bent, the patient still walks with the limb. It puts a lot of stress on the replaced joint. So both sides are deformed, better to replace both sides. Maybe depending on the patient's fitness, the elderly gentleman, I will advise a surgery after a 1 month gap, or if you are a fit individual, maybe 1 week gap. That's what the protocol we follow. We allow a 1 week gap, and if you are a very young patient like 40 years, we do it in the same sitting, same day, simultaneously. We do both sides. So the timing is based on the patient's fitness, and generally we advise both sides. If you do only one side, then put a lot of stress on the operated side. And second question, osteoporosis. I don't think there is any correlation between osteoporosis and arthritis. But the problem is where we are replacing the joints bones are very weak. So the component fixation could be compromised. We might need to use some extra metal, like a long stem inside or extra long rod to fix the components. As such, arthritis and osteoporosis, there is no correlation. But arthritis can predispose to osteoporosis because we are not walking. Many patients just restrict their life inside the house, they don't walk, and it aggravates the osteoporosis. If a patient with severe osteoporosis, we first put them on calcium and vitamin therapy, improve the bone strength, then take them, and we don't wait for the bone strength to come back to normal, but only when the patient starts walking, the bone strength is restored. Drugs alone don't restore the bone strength. That's loading of the bone to restore the normal bone strength. So we give them medications for a short while and do the surgery and let them walk, and gradually the bone strength comes back to normal. Osteoporosis is treated. It is treated simultaneously.
Maybe also what are the major contraindications for the knee replacement? You can explain on that, contraindications of...
One is any source of infection in the joint previously patient had any infection, or previous injury with infection. Any localized infection in the joint is absolute contraindication. If you do a joint replacement, it's again going to get infected. So second related contraindication is any source of infection elsewhere in the body, like a dental caries, skin infections, or a repeated urinary tract infection, or a lung infection. All these are relative. Mainly contraindication is infection. They are the only major contraindication. Otherwise, relative contraindication includes when there is muscle weakness. If, like a patient with a poliomyelitis, they have weak muscles, they are not able to control the joint. They also have arthritis, but joint replacement tend to fail early in them. So we need to do extra care while doing replacement in these patients, maybe use a different type of joint. Not absolute contraindication, but it is a concern when you do a joint replacement. These are two things. One is infection, second poor muscle control. Other than that, there is no contraindication.
Is it advisable in secondary osteoarthritic conditions due to rheumatoid arthritis or anything, or is it deferred? Like any other systemic diseases which is leading to a joint arthritis, whether there is any?
Rheumatoid arthritis, we routinely do joint replacement. It's not a contraindication. Other problems include systemic lupus erythematosus and other patients with hemodialysis. They are slightly prone for infection, slightly more prone for infection. We need to keep them under observation for a quite longer time. We need to put them on antibiotics for a longer time. The risk of infection is always there, but we can go ahead with the surgery. We need to cover them with antibiotics. There is not a contraindication. Restoring mobility is a priority. Secondly, age, we think from 80 years or 90 years, is it necessary to do joint replacement? And we need to see the pros and cons. If the patient is always fit for a surgery, it's better to undergo the surgery. Many patients is asked only 80 years, whether is it necessary to undergo surgery? It's very important in that age to be independent. All the elderly individuals like to be independent. And they need to be mobile to keep their lung and cardiac fitness and keep the muscle tone intact. So in that age, if they are fit, we advise surgery. So age is not a contraindication, and other systemic problem is not a contraindication. Only infection is the only thing we are otherwise we can do all.
In the field, we have seen that patients walking so comfortably post-surgery, but many a times in Ayurvedic clinics, we have not seen patients walking so comfortably even after surgery. We would like to know what are those conditions where the joint replacement surgery is not as successful? What makes it not successful?
You see, osteoarthritis, I put up a slide showing what are the joints that are affected. First is the knee, second is hip, third is the spine. So patients having associated spine diseases or neurological diseases, they don't walk very well. When one example is our former Prime Minister, Vajpayee. After the knee replacement surgery, he didn't walk well. So one is he went in a wheelchair to 10 years even, and then come for the surgery. They didn't do well. The muscles are all wasted. The muscles don't work. Even after 1 year of continuous physiotherapy, they have difficulty in walking. Second thing, there is associated spinal problem. The knee problem is more severe, so they first come for the knee surgery. The spine problem is not severe. They appreciate it only as they start walking. The spine compression in the spines are revealed only after they walk at least 500 meters to 1 kilometer. Then the spine problem is revealed. So these patients won't do well. They need to come back, get their spine evaluated, and have appropriate treatment for the spinal problem. The patient coming very late or associated neurological problem don't do well. But still they can be treated, continuous physiotherapy, they improvise. But overall, if you do a joint replacement, only 85% of the patients have good and excellent results. Remaining 15% have moderate results. There is some pain which is not from the joints, from the muscle or the nerves, which will have some symptoms. But overall, the quality of life is improved.
I think that's the message for the Ayurvedic community also, because there is generally a procedure, means patients also feel to postpone the surgery as far as possible to avoid it. So maybe if it is not responding to common effective conventional treatments and the quality of life is severely affected, I think it is that's the time to refer the patient for surgery. Usually we have 4 speakers here, 3 speakers, and 2 of them are very popular Ayurvedic orthopedians, Dr. Srivalsan and Dr. Habib. And we have Dr. A.N.N. Nandi and Dr. Arati will be speaking on the Ayurvedic management. Any more questions? Thank you, Dr. Dhanashekara.